there are a whole lot of tests that can be done to diagnose a case of TB, but not all these tests are meant for detecting drug-resistant TB, which is primarily based on culture and DST, which is still the gold standard in spite of the whole genome sequencing that is there very much around the corner. And much of the molecular platforms that are popular these days, which includes GeneXpert, which is called as the cartridge-based nucleic acid amplification test, the Expert MTBREF Ultra, and we also have the option of Expert XDR today. So early diagnosis is a concept that I have seldom understood. Early diagnosis means you're able to catch the disease much earlier than it otherwise would have been caught. What we are talking about is rapid diagnostics. So which of these can give us a result within a specified turnaround time, which is convenient for patient care. Some definitions have changed, and I thought we should be on the same page as far as this is concerned. So there is something called as pre-XDR TB, and there is called as XDR TB. XDR TB today is meant to be that which is caused by Mycobacterium tuberculosis strains that fulfill the definition of MDR TB or just RIF-resistant TB alone, that are also resistant to fluoroquinolones and that are also resistant to at least one additional group A drug, which includes bedaquiline and linezolid. So as a clinician, orthopedician, what are the things that the lab expects you to do? The lab expects you to collect the right sample. That will be from the site of infection, like we had case 1. So if it was possible to collect from the deep-seated infection through a guided biopsy or whatever you use to guide the collection, please do it. Don't refrain, don't restrain yourself from doing it. Now, I was wondering about this inconclusive reports. Now, have we asked for all the tests and have we given them the right amount of specimen? Because I believe that extrapulmonary tuberculosis, and in this case, since this is about spinal tuberculosis, it may not be possible to go on collecting multiple specimens from the same patients at different points in time. So if it's possible to collect a whole lot of specimen, the maximum quantity that can be collected without affecting the structural or the functional component of that particular site, then please go ahead and collect. Don't feel shy of collecting an adequate quantity of specimen. Why do we need an adequate quantity of specimen? Simply because these lesions, irrespective of ultra or supra-ultra, are paucibacillary in nature. You never ever are going to have 16 bacilli colony forming units per ml of that specimen. It's going to be much lesser than that. It's only because it gets amplified that we are able to detect it through the molecular platforms. So the most important thing here is to ask for collect an adequate quantity. And the other thing is, don't just ask for GeneXpert alone, okay? Ask for GeneXpert and culture, GeneXpert and culture. They have to go hand in hand. Until such a time that we get whole genome sequencing results, that is the path that we need to take. So I wonder whether all the discussions that we had about case 2 was all about not sending an adequate quantity of specimen, not sending the specimen every time for culture, and not asking for the right platform to choose. Then the specimens have to be collected in a sterile container period. You don't have to add anything to it. But remember not to add formalin to it. Even if it's a molecular platform, do not add formalin because sometimes it can give us false negative results. Appropriate choice of test, like I said, always it should be a combination of a molecular platform and a culture and nothing more and nothing less. And timely reporting notification for accuracy of the identification as well as for starting effective treatment to the patient, because that is the crux of all this discussion. So experts should be used in all cases, irrespective of age, irrespective of gender, irrespective of the type of TB, irrespective of the pre-test probability. What we are missing here is the TB mimics. All cases of lesions that look like tuberculomas or tuberculosis need not always be caused by Mycobacterium tuberculosis complex alone. Nothing other than this will be detected by the molecular platforms. You need to choose some of the molecular platforms. The kind of molecular platforms that we are harping about, which is the GeneXpert, the TrueNAT, they only detect Mycobacterium tuberculosis complex. So if you have an infection with non-tuberculous mycobacteria, if you probably have a TB mimic there, like we had a peculiar case of a fungal infection over a TB infection which responded to antifungal agents more than it responded to anti-TB agents, those things will never get picked up. So you always ask for a complement of tests. So look for this, look for this, look for this, also look for TB. And the test you use for TB is the molecular platform as well as culture and DST. So the initial molecular platforms that you use, which is called as the initial diagnostic test or screening test, is always going to be your Expert MTB because it's available. You get different kinds of results like this. MTB is detected susceptible, MTB detected resistant, MTB detected indeterminate. When you have to run another sample, and if there's an error, obviously there will be a second sample there. Then we Sorry, I didn't get your name. So doctor did mention about this being more sensitive than Expert alone. Expert Ultra is available in corporate labs. It's not available under the program. If all of you are from the corporate setup, fair enough, go ahead and ask it. If you're not under the corporate setup, you are working under the programmatic conditions, then this particular test is not available as of today. It is much more sensitive than GeneXpert, and use it for all the indications that you have chosen to use it for in case of GeneXpert. So this is the test that I was speaking to you about, which has just come around the corner, and that is Expert XDR. So in case of Expert XDR, it gives you both first line results as well as second line results. So you do have, conveniently you have to do, so this is an add-on test. MTB has to be detected, rifampicin has to be resistant, and then you can choose to use this test. Or you can even choose to use this test even if rifampicin is sensitive, to rule out any other resistance, whether polyresistance or monoresistance. So that is something that will be soon available under the program also, but maybe a little down the line. So these are the add-on tests that you have, and you also have this concept of line probe assays. So when we said that the initial test results said that it was rifampicin sensitive, there is this concept of what is called as reflex testing. This is what I want us to understand. So there is this concept of reflex testing when the clinician is not expected to ask for what is the test that needs to be done. If MTB is detected, fair enough. There are two options there, rifampicin sensitive or rifampicin resistance. In both cases, an LPA is done. If it's not done by A lab, it is sent to a B lab where this particular test is done. Only it has to be a certified laboratory. So when you do an LPA, what is the advantage? First line LPA in RIF susceptible gives you more information of INH. And in case of RIF resistance, the second line LPA is done, which gives you more information about the second line drugs. And finally, you also have the option of culture if you do not get any reasonably good results that you can use for treating your patients. The disadvantage of LPA is, while we saw that the limit of detection of Expert was around, let's just say 131 or 16 colony forming units, depending on whether it was Expert alone or Expert Ultra, in this particular case, you need about 1,000 organisms. So it's usually recommended only in smear positive cases, whereas the second line LPA can be done irrespective of the smear status. So these are basically follow-on tests. So if you have ever read the LPA reports that you receive, you will always have reports that say that resistance is detected or resistance is inferred. So when resistance is detected, it only means that that particular drug cannot be and should not be used. When resistance is inferred, it means that there is probably a low-level resistance, and therefore you could choose to use a higher dose of the product if that is permissible for that product, which is true in case of INH. So after doing all these discussions, we look at, is there a role for culture at all? So you have a high probability of TB, and all your molecular platforms are giving you negative or inconclusive results, then culture will help you, because culture always detects only viable bacilli. So there is no question of a patient being put on treatment for 12 months and then you have a GeneXpert result that is repeated. You get a result that still says it is detected, and you do not know whether it is because of viable or non-viable bacilli unless you clinically correlate it well with what is happening at that particular site. When you know that there is a high probability of resistance and still you get susceptible results, maybe you would want to repeat the culture. Discordant results between any two molecular platforms also can be solved in most of the situations, though not in all, by doing a culture DST. So the summary of this is, whenever you're thinking of TB, if it is extrapulmonary TB, always ask for a molecular test and always ask for a culture, both at the same time. Do not wait for one to happen for you to ask the other, because by the time you ask the other, there might not be sufficient sample to do the test properly on. Is there a role for smear microscopy? So like I said, we are talking about extrapulmonary disease, we are talking about spinal tuberculosis. 90% of the time it may be because of tubercle bacilli, but there is a 10% chance that it is because of TB mimics. These TB mimics can only be detected if you do a simple microscopy, you do an acid-fast stain, you do a culture, and you do a KOH preparation and a fungal growth. So all these things can be ruled out in this case. There is also a role for smear, there is also a role for culture, because Expert does not detect non-tuberculous mycobacteria, Expert does not detect fungus, Expert does not detect any other bacterium. So this was the flow chart. First thing is you ask for a nucleic acid amplification test, then a line probe assay, which could be first line or second line. That is the reflex testing that you do, and culture in all cases of extrapulmonary TB. So this was our study where we found that in cases of spinal tuberculosis, you can get a good culture positivity provided the sample is a tissue, which gives you twice the detection as compared to something that is called as pus, aspirated pus. So TB bacilli are there in all lesions that look like tuberculosis. They can be differentiated from other organisms. It's only that the human mind has not evolved so much to find out that test which can detect all tuberculous disease. These have been the points of reference for this presentation. Thank you very much.